welcome to Rebooting Our Health System, Virtual Care Solutions in Action. Before we begin, I'd like to acknowledge and celebrate the fact that we are on the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, and the Tsleil-Waututh nations. And I'm grateful to be here today. My name is Megan Kavanagh. I'm with the BC Patient Safety and Quality Council. For those of you who aren't familiar with the rapid fire format, we break out the time into 3 chunks where we've got a 10-minute presentation followed by 8 minutes of discussion and questions, and then 2 minutes to switch between presenters. Unfortunately, we recently discovered that our last presenter is ill, so that is Anna Coslet from Fraser Health. She won't be able to join us today, so we will be ending a little bit early, but you can view her presentation online or on your app. So, the other thing I would like to let you know about is that this session is going to be live streamed, so it's important if you're asking questions, please wait until the microphone gets to you so that our viewers can listen to your question as well as to the response. And we'll get started. I'd like to hand it over. Thank you.
Hi everyone, thank you for joining our session for BC Cancer's pilot and remote patient monitoring and for eating your chocolate cake really quick to get here. We have nothing to disclose. We also like to acknowledge that we are speaking to you today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. And there's a phrase I learned recently that goes, that means, are you good or are you well? And it goes, choch mahakt, and it's in the Squamish language. You often hear people say, manifest what you want and speak it out loud. So words are really important. Now, I'm not Indigenous, I'm Iranian by background, and when someone who's not Iranian and speaks Farsi to me, my face lights up. So we play, we work, and we speak on these lands, so we find ourselves responsible to learn the words that were spoken on these lands and continue to be spoken on these lands. And with that, I'd like you to introduce you to our team. My name is Mehdi. I'm a senior leader at the Office of Virtual Health. I'm joined by Sunny Vafi, who's a senior clinical leader, and Annie Chen, who is a specialist on our team. I also like to give a personal shout out to Nahida, who helped us put this beautiful presentation together. With that.
Amazing. Thank you, Mehdi. At BC Cancer Victoria, the patients with head and neck and lung cancer undergo a dual modality treatment that includes both systemic chemotherapy and radiation therapy. As a result of this treatment, they may experience a wide variety of side effects that may require them to connect with their care team for treatment or at times visit emergency department. The Office of Virtual Health collaboratively worked with BC Cancer Victoria clinical team to trial a remote patient monitoring or RPM trial. The goal of this pilot was to determine if RPM was an effective type of model of care in empowering patients to communicate their side effects to their care team in order to receive appropriate and timely treatment for them. The objectives of this pilot that were 4 were to empower patients to be more involved in their care, allow the care team to monitor, respond, and treat patients' symptoms timely but also proactively, improve patient and family experience, and also minimize in-person visits during the pandemic.
So before we get into the major lessons learned throughout the project, I'd like to set some groundwork by talking about how clinicians as well as patients use our system. So within the patient perspective, there are 4 main components, the first of which are the devices. Within this program, patients use a 4G tablet, a Bluetooth oximeter, a Bluetooth thermometer, as well as a weight scale and pedometer. All of these devices were completely vendor managed from when they're being delivered to the clinical care center any troubleshooting that may be required while the patient is on the program, as well as pick up once the patient has been discharged. The main feedback from patients was that the Bluetooth functionality didn't always work. So this means that occasionally patients would have to manually enter their biometrics into their questionnaires. And this leads us to the second part of the patient component, which is the general schedule. This includes things like how often patients had to complete each questionnaire, as well as which questionnaires they had to complete. As you can see from the slide, we had a variety of questionnaires, some to be completed daily, some weekly, and some bi-weekly. We also had a quality of life evaluation questionnaire that was completed only 3 times throughout the patient's journey. Once when they're enrolled, once halfway through the program, and once right before they're discharged. Overall feedback from both clinicians and physicians was that we could have decreased the number of interviews as well as the frequency of some of the other interviews. The third patient perspective or component really revolves around the question types within the questionnaires. Question types included biometric questions, rated questions, informational text steps, as well as multiple choice questions. While patients and clinicians did appreciate the variety of question types, they also wished that there were some way for a patient to clarify, especially with yes or no questions. And the last component is the educational materials. So these took the form of attached PDF documents or links to online resources, and as you can see, they cover a wide variety of topics, including anxiety, constipation, and fatigue. The feedback from patients was that they did find these useful for managing and understanding their side effects. And now on to the clinical perspective. So what the system really helped the clinicians with was triaging, and it did this by using 2 main types of alerts. The first type of alert is triggered based on a patient's answer to specific questions within the questionnaire. And the alerts that are usually of note are significant or marginal alerts. And these are pretty much decided by the clinician as we're creating the interviews. They may decide, hey, this answer might be a little bit worrisome, and we would want to check up with the patient on that. So when a clinician does receive this type of response, or this type of alert, they will look at their baseline data and see if it is actually abnormal for that patient to have this response. If so, then they will contact the patient, and they may also contact other healthcare providers if they believe escalation of care is required. The last type of alert is the missed interview alerts. This pretty much just means the system did not receive any completed interviews from the patients during the expected time. So when this happens, the clinician will look at their file and see if there's possibly a reason that may have already been given by the patient for why they could not complete this interview. If so, that's great, and they'll move on. Otherwise, they will contact the patient and see, was there some technological issue that prevented you from submitting the alert or submitting the interview, or were there some other causes? And now I'll pass it back to Sunny.
Thank you, Annie. Although the objectives of this project were achieved, there were 3 categories of lessons learned that we learned through this project. The first category is related to the patient population that was selected for this pilot. And in this case, it was patients with head and neck and lung cancer were selected because of due to the requirements as part of their protocol to be connecting with their clinical team regularly. During the initiative, however, it was realized that RPM wasn't necessarily required, as these patients were already receiving weekly calls from their care team, specifically their nursing group. And to truly evaluate the impact of RPM model of care, selecting a patient population that doesn't have those pre-existing connections with their team care is very important. And the recommendation is for future pilots to select a patient population that have less invasive diagnosis. The second category of lessons learned is around the patient enrollment. The enrollment plan included a target sample of 50 patients. However, we were able to only enroll 10 patients into this pilot, and only 6 were able to complete the final evaluation survey. The target was not achieved because of three categories. The first was related to lack of awareness of clinicians who were meeting with these patients regarding the RPM pilot, which led to a number of eligible patients not being enrolled into the project. The second was around members that were assigned to enroll patients into this pilot not having capacity to fully enroll and complete the process for those patients. And the last one was related to the pandemic, resulting in delay in patients' diagnosis process, leading to patients not being eligible to participate because of the severity of their illness. And our recommendation is to enhance education and communication of RPM pilots for clinicians, so to increase identification but also enrollment into for all eligible patients. Also allow multiple clinicians to process these patients into the pilot to reduce workload that are specifically assigned to specific individuals. The last category of lessons learned is related to the data limitation. There was no baseline data collected for this pilot, and this data included number of treatment delays, number of unplanned appointments, number of canceled scheduled visits, but also safety events involving enrollment. Also, as Annie was mentioning, there was inconsistent number of patients participating in the survey between baseline, midpoint, and final, which led to difficulty in making a direct comparison between the three patient survey points. I'll pass it back to Mehdi for conclusion.
As you can see, I got introduction and conclusion, so I got the easy parts. To essentially bring it all together, what we understood was that detailed assessment of the patient population's model of care is extremely important to determine if RPM is even appropriate. Other things we learned is that continuous change management to make sure training, communication, everything is in order with all the people who are impacted throughout the life cycle of the pilot is done consistently throughout the pilot. Lastly, even though we had all these challenges, there was enough evidence to show that remote patient monitoring is here to stay. Out of the 6 patients that did do the satisfaction surveys, 5 of them were very satisfied or satisfied. And the providers thought that the quality of RPM was acceptable. Now, that's a good start, but our goal is to improve. And I'm lucky to say that we're already piloting another initiative at BC Cancer Kelowna, taking on some of these lessons learned. And hopefully we can come back in the next quality forum and tell you guys what we learned there. Any questions or answers? Thank you.
I also work on something called the Canadian Cancer Trials Group, and we're talking about, doing some research in this space. So that was going to be my question for you. What do you think the best opportunities for research are for actually furthering work with this? Because we're talking about that now nationally.
You can try it.
Yes, for sure. I can try. I'm going to try. So in the new pilot that we're doing, we actually did collaborate with the research folks to have a research paper side to the project. So we are hoping to be able to do that more and more through our projects to incorporate research stakeholders within the project so we can document.
Hi, thank you guys. That was a great presentation. I was wondering if you could speak a bit more about the devices and the data flow that come from them, because it sounds like you're using multiple devices. Do they all connect together to create a report? Does the data is it continuously monitored, or is it just, could you speak to how that all worked and how that might have impacted your uptake and the lessons learned that you have?
I'll be speaking to this one. So they were not continuous monitoring. The various devices were all you had to measure when the questionnaire asked you to measure it. And all of these devices, as you can tell, some were Bluetooth, some were not, but they all collected data within the tablet, and everything within the tablet is then sent to what we're going to call the clinician's portal. And so the clinician will be able to see all the responses that patients put in. Does that answer that part of the question? And then the last part was,
Do you think that like this oriented system for the patient might have impacted how they were satisfied with it or how they used it? It just seems like a lot of.
I definitely think, if we had less devices, then it wouldn't be as cumbersome for the patients having to switch between this device and that device. Some devices are Bluetooth, some are not. And, if the Bluetooth functionality was more stable, then that would also make it easier for the patients for sure.
I guess I can add to that. And this is a great point we bring up because these are the gaps that we learned from Victoria that we may not have asked those specific questions, but hoping to get a little bit more detailed information from that experience side of it, both for patients and families, but also clinicians with the BC Cancer Kelowna work that we're doing.
Hi there. Thank you for your great presentation. I am part of Fraser Health Group that implemented a similar initiative in rural and remote areas of the east areas of Fraser Health. And I'm curious about what did you do with the data? Did you involve medical providers or other allied health partners to assist with dealing with some of the symptoms or instability that came through the data readings that you were getting?
Sure, I can try to answer that question, and I'll be transparently honest that some of us were not part of that project right from the beginning and joined halfway or towards the end of it. But what I've learned is that there were surveys sent out to the clinicians to gather their experience. But what I've learned was that there weren't so specific questions that we were able to answer to the area or stages of their assessment that could have improved. And we're trying to modify those survey questions for the Kelowna group so then we can learn specifically both from the physician side as they go through identifying patients, but also from the clinician side, depending on what part of workflow they're involved, to learn more about their specific experience for this.
Thank you. Great presentation. I have two questions. The first is you talked about the importance of assessing the patient population, and it sounds like you have some good learning. So I was wondering, first of all, how did you choose to focus on this for this pilot? How was it selected? And have you developed any sort of tools or frameworks for others who are looking at remote patient monitoring that could be used to make sure it's really the right fit before moving forward with the pilot?
Yeah, absolutely. I can start. Sounds great. So for this pilot, this patient population, so head and neck and lung, were specifically selected because they, as part of their treatment, they required that frequent connection with the clinicians. And to reduce the workload essentially from that part of the workflow, we were trying to see if RPM can support it. But at the same time, we have to understand that weekly calls to those patients specifically is part of the protocol for that patient population, and not being able to remove that connection point on a weekly basis, we weren't able to truly evaluate RPM. So what we are trying to do for the next population is that grabbing a group of patients that doesn't require that weekly connections with the clinicians as part of their treatment protocol, to be able to truly assess how RPM is enhancing their experience, but also evaluating workload with regards to the operational efficiency piece of it. Hope that answers your question.
Just in follow-up to the where did the data go question, like what EMR or EHR did it land in, and like how often were clinicians required to review the data? Or perhaps it sounds like you maybe sort of front-ended those expectations by setting up the survey intervals. Is that what happened?
Sure, I'm going to try to answer some of the some parts of your question. So with regards to EMR, the data wasn't directly linked.
No.
The data was not directly linked to the electronic medical record, and that's something that we're experiencing with different virtual health solutions that we work, and especially with different clinical programs across the province. Having different EMRs gets a little bit challenging. But one piece we learned is that we set certain metrics that we were hoping to measure, and when we got to the evaluation piece, realized that understanding there are different ways of documentation and different EMRs, we weren't able to gather that data. Knowing that patients will go to, for example, in this case, BC Cancer Victoria for their treatment, but if they have an emergency, they may go to multiple emergency departments that we don't have access to their database. So for the future, or the work that we're doing with Kelowna, we're narrowing that down. So trying to identify a way for the clinicians to be able to document for those patients that are enrolled into this pilot, as in their visits to the emergency department or their visits to the clinic that was outside of their routine scheduled visit, to be able to pull some data for that population instead of having nothing to work with. And the difference that we've done between Victoria, or the different model that we've approached between Victoria and Kelowna, is that with Victoria, the pilot was done with a group of clinicians that this pilot was essentially added to the workload that they were already doing. So it was always acknowledging that with regards to capacity, what they're capable of, or they have the capacity to do it, versus Kelowna, we were actually lucky to be able to have a nurse who's dedicated to this pilot. So we're able to direct our data collection a little bit closer and narrower so we can evaluate it at the end of it, which speaks to the operationalizing this down the road, being able to speak to that there may be extra resources potentially required for that section of workflow, with a hope of making the entire workflow more efficient from the operational perspective, but also enhance the experience for patients and their families.
Thank you, everyone. That was an excellent presentation. Thank you. And now we are going to hear from Kevin Waldorf.
We are.
Go ahead.
We are going to hear from me. So green means go, I'm assuming. So hopefully you guys had a good morning. My morning was all talking about disasters, so I'm happy to talk about stuff I love. Well, I love this. Hopefully you will when we're done here. Before I get started, I'm going to do a land acknowledgement. So we are on the shared traditional, unceded, and occupied territories of the Coast Salish people, specifically the Musqueam, Squamish, and Tsleil-Waututh nations. And along with that, as an occupier of these lands, I acknowledge my responsibility of working towards achieving meaningful reconciliation with those nations. So I am Kevin Waldorf. I'm an OT for 15 years, and I am a clinical planner with our virtual health department at Vancouver Coastal Health. And we're going to talk about virtual interpreters. So I have nothing to disclose for this presentation, and the icon images are provided by Flat Icon. So if you like any of them, you can get them from there. So show of hands, who's heard of or used virtual interpreters, remote video interpreters, interpreter on wheels? Lots of you. So you guys are familiar with this. Good, perfect. Okay, so what is a virtual interpreter? Well, for us, it looks like that. So at Vancouver Coastal Health, that's what our virtual interpreters look like. They are iPads with remote video interpreting apps installed. They are encased in a sound amplifying case, and they're on wheels, much like a medical stand, so you can move them around. The app has 240 languages in audio available 24/7. That has 40 languages in video, and it has a connection to a live medically trained interpreter in less than a minute. And in some areas, our staff treat the virtual interpreter like a staff member. One of them is named Rosa after Rosetta Stone, and one of them is named Wall-E after the robot from the Disney movie. So why do we need virtual interpreters? Well, particularly in Vancouver Coastal Health, we have a population of about over 50% of our residents of Vancouver who English is not their first language, and that's actually higher in some areas of our health authority. There's an estimated 21% of healthcare clients have low English proficiency, and that's up to 75% in some of our facilities. The length of stay in hospital was measured to be 37% longer for clients with low English proficiency. And we have gaps in access to current interpretation services. We have no access to medical interpreters for the hearing impaired, so people who use American Sign Language. We have limited access to phones at the actual point of care to use phone interpreters. So phone interpreters are great, but not if you don't have a phone beside the patient. We have no access to in-person interpreters at our rural sites. They only had access to phone interpreters in the past. And 8% of our requests for in-person interpreters go unfilled. We simply can't get an interpreter when we need one. So this is a brief outline of our project implementation. So this project started back in 2019 with a pilot at select sites. So they chose acute and ambulatory sites to pilot. And key highlights from that pilot project, I believe there was 15 sites included in that, and key highlights were there was a 28% reduction in time to admission decisions in ER, so doctors were able to decide whether someone needed to be admitted faster. There was a 47% reduction in length of stay on the units they measured, and there was a 69% reduction in 7-day readmission rate, because if you discharge a person with proper instructions and they understand them, they probably won't come back. In 2021, which is actually when I joined the project, so I joined the project right before we did a massive implementation. So we implemented to all acute and ambulatory sites. We implemented 96 additional devices to 86 areas. We developed a sustainment and device reallocation plan so that we could be certain the devices were in the areas that needed them the most. And in that one fiscal year, we placed over 31,000 calls with the virtual interpreter and recorded 301,000 minutes. And the average call length was 9.69 minutes. In 2022, which we are in the middle of right now, we are piloting in long-term care and home support. We understand that there is different needs for interpretation in long-term care and home support, so we've expanded our use criteria to meet their needs. We are testing mobile device options and alternative sound options, and we are testing the service via cellular data, because currently with the devices, they are hooked up to Wi-Fi in the hospital. They are not using data for that. And then in 2023, our hope is to expand to all remaining areas so that every area has access to virtual interpreters, the goal being that in the future state, if you receive healthcare at any of our facilities in VCH, we can have an interpreter for you within a minute. So what are the benefits of having a virtual interpreter? Well, for us, it provides video interpreters in rural areas with no access to in-person interpreters whatsoever. It has access to on-demand medical interpreters for the hearing impaired, and this is particularly important at some of our ambulatory and community sites. We actually had patients that only used American Sign Language to communicate, and they would drop into healthcare centers. And besides doing the little charades and writing stuff on pieces of paper, staff had no way of meaningfully communicating with those patients. So it did provide them. They were very happy when they found out that they would actually be able to receive their health care. It provides timely access to healthcare and services. This is particularly important in our ambulatory care areas. We heard time and time again when we implemented into ambulatory that patient appointments are so intricately linked to having availability of an interpreter that sometimes people's appointments were delayed by weeks, if not months, just to get an interpreter available, because they would book it. The interpreter suddenly isn't available when they book the appointment. They would need to rebook the appointment again and again and again. They don't need to anymore, because there's 240 languages and most people are covered by those languages. Other areas where it improved access to is some of our mental health and substance use areas. We had areas that patients would not access care simply because they didn't feel comfortable accessing care in a language they were not familiar with. So they didn't seek care. Now they can, because they can feel comfortable that we can actually communicate with them when they actually go to receive care there. Virtual interpreters also could potentially decrease length of stay and lower readmission rate. They will enhance the patient partnership because it improves access to interpreters. Patients can participate in their care, not just the moments when there's an interpreter available, anytime, because we can get an interpreter for that 10-minute conversation with your nurse, for that 30-minute conversation with your physio, for that discharge conversation with your physician. And it also decreases the burden on multilingual staff to provide interpretation. Other staff members are used consistently to provide interpretation, and it requires them to do double duty. We want our clinical staff to focus on the job we're paying them to do, which is to be the nurse or the occupational therapist or the social worker or the dietitian. We don't want them to be an interpreter on top of their already busy workload. Now, that being said, there are limitations to the virtual interpreter itself. There we go. It is costly, but with a 9.69 average call length, it's actually cheaper. So when your average call is less than 10 minutes, it's actually cheaper to use this service than it is to book an in-person interpreter. It's not ideal for highly sensitive conversations. If you were choosing to have or if you were going to have a conversation with someone about possibly discontinuing care with their loved one, I probably wouldn't use it as my first choice. I'd probably look at using an in-person interpreter in those cases. It is not ideal for conversations that require hands-on demonstration. So if you're teaching a patient a skill for discharge, it's probably not best to use the virtual interpreter. You can, but it's probably not your best choice. As with all devices that are hooked up to Wi-Fi, there could be potential connection issues. Some clients prefer in-person interpreters. They prefer in-person care. They're not quite ready for virtual care yet. We have to recognize that in our debate we had yesterday. We know we have to recognize that, so we have to make sure we're meeting the patient's needs when we can. And the device stands that I showed you before are obviously not suitable for home-based or outreach services. They are very heavy because they are medical-grade stands. I tried to carry one upstairs. It is very heavy to do. So we're gonna have to look at mobile device options, which is what part of our long-term care pilot is looking at doing, is whether it's useful on either tablets and or mobile phones. So what did we learn from this project? Well, what I learned from this project in particular is you really do need to understand the interpretation needs of the areas and services you want to implement it to. Don't assume every area has similar interpretation needs. The interpretation needs in our areas of Richmond are significantly different than, say, our international ski resort in Whistler versus the interpretation needs of our rural communities. They all have unique needs, and you do have to understand those needs so you can meet their needs when you're actually implementing to them. You want to establish site selection criteria with your leadership and follow them. You want to make sure that you're putting the services where they're needed most and they're going to be used the most. It would be advantageous to trial new or unique areas before you implement. So after we did the big widespread implementation across all of our acute and ambulatory sites, we recognized that as we add new sites in, we're best to pilot them for 3 months, let them get used to the device. Then we can also give them some feedback on when they should and shouldn't be using it so they integrate it into their workflows a little bit better. You do need to consider and validate the feasibility of sharing devices. An area like our VGH Emerge uses 10% of the usage across all 130 devices we have. So they're a big user. They only have 2 devices and they still make up 10% of the usage. And so that area doesn't get to have to share because that area needs it all the time. We're actually considering adding additional devices to that area. So you do have to consider that. And even when you're looking at infection control procedures and how the units are laid out, it's not as simple as, oh, just go grab it from down the hall. You do have to look at whether that's actually feasible for staff to actually do that in the moment when they need it. And the last thing we learned is you need to create a thorough sustainment plan to avoid cost overages. This project could get very costly very quickly because you're paying per minute for service. So you do have to be careful that you're actually monitoring that. And as part of our sustainment plan, we actually monitor every single piece of data that comes in. So when we get billed from our vendor, every single call is billed by the minute, whether it's audio, video, and every language. So the data we have is actually put into a dashboard where it tracks every single thing. So we can monitor all long calls, all short calls. We know which unit uses it. We know which unit has seasonal usage where they might use it heavily in a couple months and then they don't use it for a while. And we follow up with them. We find out, why did you use the interpreter for, 4 months straight and then you haven't used it since? Well, if they're a tertiary mental health unit, they might only have people admitted every 6 months because people have a longer length of stay. So we recognize that if you have one person admitted there with low English proficiency, they're going to be using the device nearly every day. Once that person's discharged, there's actually no need to be using the device after that. So we recognize some of those areas and we recognize that we might need to adjust use criteria to actually meet those needs. And that is it. Questions? Ooh, people got questions.
I was just curious regarding the costs in relation to just calling PLS or pre-booking PLS by phone.
The cost difference?
Yeah.
So generally with this service, we average, if you're going above 20 minutes for the conversation, it's cheaper to have an in-person interpreter. That being said, there's additional costs associated with in-person interpreters, their transportation time, their parking, stuff like that. And so when it all costs out in the end, It depends on how long the conversation is. Generally, anything under 30 minutes is actually cheaper with the virtual interpreter. If it's over 30 minutes, it will probably cost you less to do that. So what we do is we do monitor those long calls. We've had situations where a call was used for 5 hours for the birth of a baby. So those types of calls we try to avoid because obviously that's a very expensive call. But we recognize there are situations where you might need to use it longer because it's going to compromise the care. And if it's going to compromise care, we say, yes, you have to use it because to go without is not worth it.
Thank you.
Any other questions?
Well, I'm really impressed you evaluated this in a prospective, systematic way because at BC Cancer Vancouver, these just arrived.
Yes.
Right?
Yeah.
And I guess what I was sort of curious about is how widely used this technology is elsewhere in Vancouver Coastal and PHSA and Fraser. I mean, is because certainly we're using it, but
So
wasn't
you
sure who
guys
else is.
are using it now. I'm
Yep.
not entirely sure how much. You guys might be able to speak to that if you know that. PHSA, my PHSA colleagues would know. Providence Healthcare is currently using it a little bit. They haven't fully implemented into it. So what VCH did in 2019, or actually during the pandemic, is we actually got a subcontract with the vendor. And so to follow up on what you were saying earlier in the cost, the actual, when you call PLS and you get a phone interpreter, it actually runs through the same vendor that we have here. So that's actually the exact same thing. So when you call PLS right now and you get an audio interpreter on the phone, it's actually using the same service. It costs the same amount whether you're using a little device or you're using the phone. And so it doesn't make a difference with that. Right now we have 130 devices. The only areas we have not implemented to in VCH right now are outreach services. So home health, which is why we're testing it in home support right now, and long-term care, and then outreach type services, so mental health outreach teams and stuff like that. They're not implemented in those because we need mobile options for them. So we need to be ensured that you could use it on a phone and the data integrity is going to maintain. Otherwise, there's no point. If you're going to go video on a phone and the data sucks, what are you going to do with that? Oh, more people.
Did you, when you were looking at the use criteria and stuff, did you cross-reference with who is on what lines when usage is high as a part of like change management so that frontline managers could like encourage or sort of revisit the use cases that the staff is employing the tool with? Like,
I don't quite understand what you're
so like who's working when it's used and who is not working, and then
we haven't done that yet, but
Yeah.
what we do, so we do follow up with teams. Most teams are pretty familiar with their, like, especially if they have like seasonal use where it's used heavily and then it's not, we recognize that. What we do monitor, the two areas that we focus on in our sustainment plan are excessively long calls, which we are now monitoring daily. And so if you have an excessively long call, we're going to follow up with you and say, what are you doing? Because that's a long time to be talking to someone. And we all know who has 5 hours to spend with a patient. Like, that's crazy. So, and then areas that aren't using it at all. So areas that aren't using it at all, then we look at re-educating those areas. Because often what happens is what we're seeing is the areas we implemented in our pilot project in 2019, they are by far using it very successfully. All short calls every time. And they're using, it's clear that they're actually integrated into their workflows because they've had enough time with it. The areas we implemented last year, some of those areas are still, we provided education to every single area we implemented to, some areas, several education sessions, but they're still trying to figure out how to put it into their workflow. Some people are a little scared because of the costs. They're like, oh no, it's gonna cost a bunch of money. And we're like, no, if you need it for care, please use it. Because what we really found with this project is it's not so much that it's replacing in-person interpretation, it's actually providing interpreters in care situations where people weren't accessing it when they should have. So when a nurse goes in to do their morning assessment and it's 10 minutes long, you're doing your head to toe, you're giving meds, you probably should have had an interpreter for that interaction. Now you can, because you couldn't before. Because most people don't have phones that they can carry with them. We don't encourage use of personal cell phones for this service. And so most care providers don't have a phone that they can use for that. And so they were just like, oh, I can go do without. And then when they actually started using it, they realized, oh, we should have been using this all the time. For a patient who has low English proficiency, it should be used in every interaction that we can. And that's what we're encouraging. We're really encouraging them to use it in those interactions. We do recognize some of our areas have longer appointments. So our rehab facility at GF Strong, Generally, they're seeing patients for about an hour at a time. So we do need to consider whether we need to expand our use criteria in some of those areas to actually make up so that they can actually use it and not feel like, oh, I'm not supposed to use it for this long. This might cost too much money. But we have to look at whether it's actually providing quality care and what you're providing from that situation.
So at Island Health, I know we're going to be doing this very shortly. I'm part of the virtual care team.
Yeah.
I was wondering just about the specific devices that you guys have. Are they running multiple, applications?
It depends on where it is. So the actual devices that are provided by the vendor only have the language line app on them. So that's all they have. They only have the app to provide it, and it's intended for just that. Our long-term care facilities we're piloting in right now, they specifically requested to use their own devices because the devices need to be multi-use. So some of those facilities have 25 tablets. So basically every tablet has interpretation and then YouTube and everything else because they actually use it for patient recreation. So a lot of patients will watch videos in their own language and whatnot. And so they specifically said, we need something that's multi-use. And so you really have to look at what the needs are. And so telling them we're just going to give you a device with language, they're like, that's not really useful for us. It's just going to take up space. But if you give us something that's multi-use, absolutely worth it for us.
Yeah, that's been the challenge for us at Island Health. I mean, all of our devices, like we've got about 200 plus iPads scattered throughout our facilities, but we have them, they're either locked down to say BC Virtual Visit or locked down to Zoom, and we can't have them running concurrent apps at the same time.
Yeah,
So-
some of the tablets are fully locked down, so it just depends on what your actual tablet is. Otherwise, the vendor will typically provide the devices for you, and you don't actually pay for the devices if you have minimum usage.
Would there be a way to look at some continuity? For example, like I also am at BC Cancer, and so sometimes you see somebody, there's going to be a bit of a break, I leave the room, now we need a nurse to come in, and so for that patient to have the continuity between multiple providers coming in sequentially, but there might be a big gap, and we do think, well, we can leave it on so we've got the same person, versus you hang up for 10 minutes, there's you not incurring costs, but there's some continuity with that. Would there be a way to pilot that to see if there's any way?
That's definitely something that's worth considering because that's the one thing we did find with some of our longer calls. That's where the issue is when multiple people are coming in, and we need to look at whether there's a benefit of having the same interpreter. Now, realistically, with medical interpreters, the intention of them is to only interpret what you say. So technically, you have to repeat it again. The interpreter should not be able to repeat previous information said in that conversation because that's not what they're actually trained or paid to do. And so they are only supposed to be interpreting what you're telling them. They're not supposed to be expanding on it or adding additional information in there, but there might be a need for that because also for patient, having the same person each time, it's more comfortable, particularly if it's a very sensitive topic. Having to bring a new interpreter in 3 times to talk to 3 different team members is probably not your best case scenario. Yeah. Oh, are we done, or are we gonna? Okay, we're done.
Afraid to say.
I'll be around if you have more questions.
Thank you very much to all of our presenters. As Kevin mentioned, they've agreed to hang around, so don't feel that you need to end the discussion now. But I will set you free. But I would like to remind you, if you could please complete your evaluation forms when you have a minute, either on your app or on the paper slips. Thank you again to all of our presenters today.